This is a tribute to all those who report their surgery on the SIGN database. We appreciate your reports, especially when you report follow-up until the fracture has healed. All of these segments were put together because they are recurrent themes when I review the database. I hope the information here will be shared with all SIGN surgeons in your program who do SIGN surgery, and we welcome feedback. Nonunions are a frequent problem that we must face in developing countries. Many of these nonunions occur from prior treatment. We've looked at the process of fracture healing, and if we can provide optimum surgery, biological and mechanical, the patient will heal well usually. If not, we must consider the fracture that goes to delayed union, non-union, and understand when to intervene. And this is the same principles that we use for good original fracture treatment. I put this mind map in to remind us that there are many factors involved in fracture healing, and the surgeon can control only a few of these, and we can't even control those completely. The surgeon must avoid being a proud rooster who crows in the morning, the sun comes up, and the rooster thinks his crow brought the sun up. There are many factors that brings the sun up, just like there are many factors that heal a fracture. Is this a non-union? This is 3 months after surgery. It's a 3B fracture. Someone might consider this a non-union just by looking at the x-ray. Then we see that the patient can squat and smile. And so this influenced the surgeon to wait and see if this fracture would heal without intervention. At 21 months, the patient returns, he's at full activity, and the fracture still has incomplete healing. And we need to study these fracture lines. We need to use the same principles of facial recognition, thumb recognition, to look at a fracture site and try to predict whether it will heal or not. This is a fracture where the fibula has healed, but there's no callus in the tibia. And maybe the fibula is holding the fracture apart and the nail is providing the stability. The patient can squat and smile. What should we do? We need to study more and more of these cases so we understand how we can help people in an optimum fashion. SIGN is in many conflict areas around the world. We treat gunshot wounds, we treat blast injuries, and I noticed that these seem to heal quicker. If they heal quicker, something different is going on, and we have studied this. This is an example of a fracture that is healed at 3 months. We studied this and we learned about stem cells from cortical bone. If you mechanically stimulate the stem cells of a cortical bone, they will accentuate fracture healing. And therefore, we developed a bone mill to try to do this. We only have 9 of these bone mills at the time, and we'll send them out to our active programs and make sure that they do the job which we intended for them to do before we manufacture more. Cerclage wires are often used. You can get away with this about 80 to 90% of the time, but I see a lot of non-unions with cerclage wires around them. Fractures of the femur should be treated differently in the 3 areas of the fracture, which are colored differently. In the distal femur, the retrograde approach should be used with a fin nail. The reason is you can see that the isthmus expands here and does not provide nail-bone contact, which decreases healing because there's decreased immobilization. We're still looking critically at the mid-shaft femur fracture. There's more non-unions in a transverse fracture of the femur in the mid-shaft. So we're looking at what we should do, the different biological and mechanical ways to treat this. For proximal fractures of the femur, we must consider that this is a high-stress area. We're also considering the sign nail with added sign plate to decrease the tension in this fracture. We must recognize the differences in stresses that occur throughout the femur and recognize that the proximal femur has high stress, but the distal femur has rotational stress, which slows fracture healing. We're still considering when the patient should bear weight in different fractures. We are also looking at placement of the sign nail in previously infected bone. This is a problem that occurs more frequently in developing countries. We're also looking at the influence of a delay between the injury to wound closure and nail insertion. We're also looking at new methods to prevent infections in open fractures, and we invite your comments on these.